folks. He has been heavily involved in deep policy work for at least a couple of decades, if not more. So another really smart activist when it comes to this stuff. All right, we're going to go ahead and get started, everyone. Thank you so much for being here. I do not think that you are going to find this to be anything but fascinating, although it probably isn't going to answer all your questions, as Dr. Slindee has made clear to us, because what we're going to talk about today, which is the 340B federal drug program. Dr. Slindee will provide a little bit of history on what that is and why it came about, and how it too has become basically another privatized, gigantic corporation in a sense, in the way that it is handled. And the reason we need to know about this stuff from a policy perspective is as we're supporting the deprivatization efforts of medical assistance, which is Medicaid in Minnesota, as well as our Minnesota Care program. This is playing a part in it, whether or not we can get there, or we have to figure out some workarounds, and he'll explain a little more what that means. But it is really, they have infiltrated everything, you guys, and the they I'm talking about is this medical industrial complex, and it's the profiteers, and it's really very frustrating and sad. It's going to take a lot to unwind this thing. So I will just tell you that Dr. Slindee is a pharmacist, and he comes from a pharmacist family. His father also is a pharmacist, and I believe you said Winona, if I am correct, and his father had a family pharmacy there, and I believe does not have that anymore, thanks to, again, all of the mergers, consolidations that's happening, where between insurance companies gobbling up pharmacies, and going to work with the CVS's and the Walgreens of the world, and doing the mail orders and all of that kind of stuff. There is no good relationships anymore between pharmacists and the patients, and it's not good for our healthcare overall. And I will let him do any other type of introduction, but it's been wonderful working with him behind the scenes with Representative Liebling and Senator Marty, who are very, very focused on trying to figure this out, and making sure that we are able to deprivatize our healthcare, or our public health program. So with that, I'll turn it over to you, Dr. Slindee. Go for it.
All right. Thank you so much. And thank you for the opportunity to speak. So, yeah, we're going to be talking about 340B today, which is a federal program. I believe it to be an inefficient hidden subsidy that uses our state Medicaid funds. So we're going to talk about that. So the agenda for the presentation is a brief introduction to myself, some context about why I am talking about this, description of what 340B is. We'll talk about whether or not Medicaid should be a source of 340B funding. I want to talk about a few peculiarities of the 340B program that I find to be particularly interesting, but have not seen a lot of media coverage around. So I want to talk about those. And then we'll talk about how 340B plays out in some of the political arena. And then we'll end with some conclusions and then discussion. And I am able to take questions during the meeting. So if you do have a question, feel free to just take yourself off mute and you can ask the question. I may respond with, that will take us off into a tangent that will cause us to run out of time. So I can follow up via email if a question is kind of really specific about something. But if it is an easy answer, I'll just answer it immediately. Sound good? Okay, so who am I? I'm a second-generation pharmacist. My family, I'm from a small town in rural Minnesota, down in the extended Winona area. It's called Harmony. And my family owned a little mom and pop pharmacy, and you can see the picture there, Slindee Pharmacy and Gifts. I have worked as a pharmacist for I have dispensing experience as being an intern and a technician, and then as a pharmacist. So I've worked inside of pharmacies for around 20 years. At the moment, my current job is I am a contractor for the federal government working in the Medicaid capacity. So I have a lot of experience related to all things Medicaid, especially the intersection of Medicaid fee-for-service, which is what I generally refer to as like the public version of Medicaid. And then, of course, there is also the privatized version of Medicaid, which is Medicaid managed care. And so I spend a lot of time thinking about the intersection of those two versions of Medicaid, and we'll talk about that. I mostly focus on prescription drug pricing, and particularly around how pharmacies are paid by Medicaid. So that ends up having a lot of effects on viability of business models and incentives and things like that. So a lot of the choices with respect to health policy that Medicaid and Medicare make end up having big outcomes with respect to how pharmacies are operated. I want to be clear in that I have absolutely zero connection to any pharmaceutical manufacturers. So the Pfizers and the Mercks of the world, et cetera. That might not be clear as to why I'm describing that to you now, but it probably will become a little more clear as we get through the presentation. So I just want to say that again, I have no connection whatsoever to any pharmaceutical manufacturers. And then lastly, I just want to be clear that any opinions that I express in this presentation are solely my own, and they don't reflect any employer that I work for or any other organization. So this is just me speaking on behalf of myself. Let's see. So why are we talking about this? This legislative session, I was part of a group that worked with Representative Tina Liebling to propose what in general terms is called a Medicaid pharmacy fee-for-service carve-out. The ultimate goal was to deprivatize our public health care programs, and the pharmacy fee-for-service carve-out specifically would make it so that all of the approximately 1.4 million patients that have Medicaid in Minnesota would receive their pharmacy benefit directly from the state government. There would not be an intermediary involved. The pharmacies just would get paid directly by the state. And that is what we were pushing for. Ultimately, I worked mostly with groups of independent pharmacy owners that were interested in this. And that is because independent pharmacy owners have lots of problems with companies that are called pharmacy benefit managers, or PBMs. So currently in Minnesota, under the Medicaid Managed Care Organization, or the MCO model, which I like to refer to as the privatized version of Medicaid, those MCOs subcontract with for-profit companies that are called PBMs, and then those PBMs actually handle all of the interactions with pharmacies. So if a Medicaid beneficiary has MCO coverage, when they go to get a prescription filled, the group that's paying the pharmacy for that prescription is actually a for-profit PBM. And that is about the case for about 85%, or about 1.2 million Minnesotans. And unfortunately, there's lots of problems with PBMs. We could have a whole nother hour talk on just PBMs, but they use their market power to strategically crush independent pharmacies. They engage in what's called price discrimination. So they ultimately use their market power to pay smaller pharmacies less than they have to pay bigger pharmacies, just purely through like negotiations terms. And unfortunately, one of the outcomes of that is that the smaller independently owned mom and pop pharmacies, especially in rural and underserved urban areas, just close. And so there's this term, deserts, which I think originated with food deserts, but now has been extended out to lots of other things. And so I am particularly attuned to the concept of pharmacy deserts, which are areas that don't have access to a pharmacy. So ultimately, that legislation that we pushed behind, again, the fee-for-service carve-out, would have completely removed those PBM middlemen. It would have made it so that the state would just pay pharmacies directly. The good news about that is that all pharmacies would be paid the same for filling the same prescriptions, so there would not be a disadvantage to small pharmacies anymore. And then the reimbursement system to determine how much pharmacies are paid would be based upon rigorous cost accounting. So that would, basically fund pharmacies appropriately. There's a whole system in place that my professional career is oriented around in terms of making sure that we pay pharmacies enough to provide the services and the drugs that they're dispensing so that they can continue. However, we don't want to overpay them so the state is not getting ripped off. So these are just some basic numbers around the privatized version of Medicaid in Minnesota. And these numbers are what I used when I testified in support of that legislation earlier this year. So the numbers are from January. And these are the managed care organizations that represent the privatized version of Medicaid. As I mentioned, they all subcontract to the PBM. So the PBMs, the biggest ones in Minnesota are Express Scripts and Prime Therapeutics and Med Impact by the numbers, as you can see. So just important to understand, this is what we were looking to remove. Effectively, we would have, if the fee-for-service carve-out would have been effective or gone through, we would have removed this middle column. The MCOs would still exist for the medical benefit, paying for things like going to the hospital or the doctor's office. But for the pharmacy coverage, that would have been reverted directly to the state, and all of these PBMs in the middle would have gone away. And so with respect to the pharmacy deserts, I am again from rural Minnesota. My hometown is on this list. Unfortunately, it's called Harmony. And so with respect to the outcomes of what's happened with the state basically handing over our Medicaid system over to these for-profit PBMs, they have caused many, many cities to just lose their pharmacy entirely. So this is a list of cities in Minnesota that had a pharmacy in town in 2006, but there are none currently. So you could consider these to be rural pharmacy deserts. And the ones that are in red, unfortunately, are ones that have actually closed since January 1st of this year. So just in the last 8 months or so, there's been 4 cities in Minnesota that had a pharmacy and lost it and now have no pharmacies, which of course means that, all the patients of that pharmacy, particularly senior citizens, are now having to either drive over to the next town, creates all kinds of access issues, or they have to receive their medication in the mail. It creates a lot of problems. But this is not just a rural issue, it's also an urban issue. So unfortunately, the monopolies also, the monopoly PBMs also disadvantage, poorer or lower socioeconomic status neighborhoods in urban areas as well. And so we saw in North Minneapolis that the Walgreens there, which I actually worked at a few times, did close. And so North Minneapolis now is also could be referred to as a pharmacy desert. So this is an issue that affects both rural and urban areas. So Minnesota, what we were proposing is not something that is brand new. It's actually been done in many other states already. And what's interesting to me here is you can see that this is a mix of red and blue states. So there's not necessarily something that's particularly tied to traditional red-blue partisanship with respect to PBMs. So you can see that what we were proposing has already been done in many other states of both left and right orientation. So just to recap, we went through the legislative session. Everything was going great. We got bipartisan co-authors, Republicans and Democrats on both the House and the Senate. I was really proud of the grassroots movement that we did. Had a lot of momentum. Our language got included in both the House and the Senate omnibus bills. Again, everything was going great. We survived an amendment challenge in the House when the omnibus bill went up for a vote. And then everything went into conference committee. And this being my first go with legislation efforts, I naively assumed that if something was in both the House and the Senate bill, then there would be nothing to resolve in the conference committee. But I unfortunately learned that that is not exactly how it works, and almost anything can change in conference committee. So unfortunately, our language was killed at the last minute. We found out basically in the last day of session that our effort to do this carve out was not going to happen. And ultimately, we found out the reason why. So effectively, there was very intense professional, by paid lawyers, paid lobbyists, opposition from several hospital-centric organizations related to what they called the loss of 340B savings. So I just want to remind you, our main focus about this bill was about pharmacies and trying to get rid of PBMs. And we were having a lot of success there, but unfortunately it was killed due to hospitals, which kind of felt like it came out of left field. The main reason for that is under the privatized model of Medicaid, MCO, that can be a source of 340B funding for these hospitals. Whereas if we were to revert to a fee-for-service system, that funding is not possible. So it would have potentially resulted in loss of funding going to the hospitals, and they lobbied very hard to kill our bill. This is an example of a letter from one of their lobbyists where they came together and brought together several hospital systems that you probably recognize. And they specified exactly how much money they claimed they were going to lose if we moved over to the public version of Medicaid. So under their telling, Fairview would have lost the most at about $31 million, followed by HCMC. I'm always going to call it HCMC instead of healthcare, but that's just me showing my age. And
Luke, could I ask a clarifying question?
Sure.
I thought you were discussing the getting rid of the PBMs, but when you described how it was the bill was killed in conference, I hear you reverting to our freedom to choose bill.
No, this is separate from the freedom to choose bill. So I think some of the same entities that killed the freedom to choose bill were the same people that killed my bill, but they are separate.
Okay, could you restate for us or paraphrase again for us what the hospital-centric organization said to the conference committee?
They said that if we did this effort to remove the PBMs from Medicaid, then that would cause them to lose millions of dollars.
Okay, I'll assume you're going to explain that later. That's the great mystery to me. I don't understand how that could happen, but I'll let you tell us in the fullness of time.
That's where we're going. Yep.
All right.
All righty. So again, these are the organizations that got involved, intense lobbying, professional lawyers versus me just doing this in my free time for fun. So we lost. And interestingly enough, after we lost, I kind of cornered some legislators to try to figure out what happened. And one of the things that I found out is that the CEO of Hennepin Healthcare actually personally got involved in making sure that our bill got killed. So that was interesting. So what is 340B? That is the question. I'm going to be completely honest with you. 340B is incredibly difficult to explain to people. It was difficult for me to wrap my head around and learn what it is in the first place. And so I have focused on, I'm going to use some metaphors that I think are very helpful because I believe that metaphors are very useful in helping people understand things. And so we're going to go on a little bit of a tangent. I'll describe some metaphors, and then hopefully that will get you in the right mindset to quickly understand how 340B actually works. Okay, so purely as a coincidence, in addition to all my pharmacy nerd stuff, I also happen to really enjoy reading novels about the mafia. And so one of the things that comes up a lot when you read books or watch movies about mafia is they have a way of making money. And what that way is, they usually strategically will steal goods, usually at some point during the transportation process from the manufacturer to the retail setting. And then they facilitate that by reselling the stolen goods. And so they steal the products, and then they work with somebody to resell them, and then they keep the money from the resale process. So again, if you watch mafia movies or read mafia books, this is a common theme. You might, there's a phrase, where did you get that? Oh, it fell off a truck. That's a euphemism for it being stolen. And then there's also a term called offense. So again, offense is a slang term. I pulled this definition off Wikipedia. So offense is an individual who knowingly buys stolen goods in order to later resell them for a profit. The fence acts as a middleman between thieves and the eventual buyers of the stolen goods who may not be aware that the goods are stolen. Now, I want to be really clear that part there is really important. You're not able to tell whether the goods were stolen or not. They get mixed in with, the regular non-stolen items. And so that's what offense does. And usually in these types of schemes, there's many different people involved. You have to pay different people off in order to get them to participate. And so there's kind of this term from mafia things where everyone gets a cut, right? That's how you ensure that everyone participates, is everyone gets a cut of the proceeds. I don't know if we have any fans of the show The Wire here, but this is a major plot point in season 2, where these two guys on the left, they are longshoremen, so they work in unloading shipping containers on the docks. You can see the shipping containers in the background behind them there. And they come up with a scheme to steal an entire shipping container filled with hundreds of digital cameras. And this is back when digital cameras were not in our phones yet. And in order for this scheme to work, they have to partner with a fence, and which is the guy on the right here. He owns an electronics store, so then he will take the stolen digital cameras and sell them to their regular customers at the regular prices. And then he'll kick back some of the money that he got from selling those cameras back to the guys that stole them originally. So that's just kind of in general how these schemes usually work. I want to switch gears a little bit and use another metaphor. So now we're not talking about stealing anything. We're talking about charitable donations. Okay. I have discovered that apparently it's relatively common for people to donate their car to charity. So as instead of donating money, they decide they want to donate their car. And so that's interesting. It's common enough that the Attorney General's office wanted to put out a, kind of an explainer on how these things work to the general public. And I want to call attention to this situation here, where it says charities will typically do one of two things with a vehicle donation. First, a charity may use the donated vehicle in its efforts or distribute the vehicle directly to needy individuals. So they might just take your car that you donate and then just give it to someone who needs a car. They may use it to deliver things, so basically they're using it directly. Now, the other option is that the charity may take your donated car and then sell it to the public or to a junkyard, and then use the proceeds from the sale to fund other charitable programs. So there's kind of this fork in the road of, you've donated a car, the charity has to decide what they do with the car. Now, on the right side, it says some charities operate their own car donation programs. However, other charities use for-profit fundraising companies to solicit vehicle donations and to sell or scrap the vehicle. In those instances, typically only a portion of the sales price goes to the charity. The remainder is kept by the for-profit fundraising company as a fee or a commission. So you can kind of see some similarities here to the stolen goods model, but we're not talking about anything being stolen. This is about charitable donations. Okay. So keep all of that in mind. So what is 340B? 340B is a federal government program that was created by Congress in 1992. It was part of the Veterans Healthcare Act, and it's codified as Section 340B of the Public Health Service Act. So that's why it's called 340B. It's kind of like 401ks. It's named after the exact section of the bill where they describe the program. So 340B of the Public Health Service Act. And this program is unusual amongst federal programs in that it involves a mandatory transfer of resources or goods from one group of private entities, in this case, drug manufacturers, to another, healthcare providers. So the government is facilitating the mandatory transfer of resources from one private group to another. This is exactly from the official 340B government website. So there are three kind of main concepts related to 340B that I want to talk about. The first is, it says the program enables covered entities to, and these are the four magic words, stretch scarce federal resources. So if you follow 340B at all, these are the words you will hear over and over and over again. Stretch scarce federal resources. As far as possible, reaching more eligible patients and providing more comprehensive services. Okay, so that really is kind of the definition of what the program is supposed to do. That's kind of it. The program works by manufacturers of drugs that participate in Medicaid. They agree to provide their products or their drugs to the covered entities at significantly reduced prices. So the drug manufacturers are selling their drugs to these covered entities at a steep discount. That's how the manufacturers get involved. And the eligible healthcare organizations or covered entities are specifically defined as to who can benefit from this. And we'll touch on that in a second, but mostly it makes up, it's different types of hospitals, federally qualified health centers or FQHCs, and then there's kind of a collection of other entities that are officially defined as part of the program. So this is a fun little infographic from a Government Accountability Office report. These are the eligible covered entities that can be the recipients of the discounted drugs that they receive from the manufacturers. I would say they fall into three main categories. There's hospitals, there's FQHCs, and then there's kind of everybody else, which includes, all these things like black lung clinics, hemophilia treatment centers, Ryan White programs for HIV. And so these are the officially defined entities that can be the beneficiaries of 340B. So let's unpack the significantly reduced prices part from the thing. 340B is directly connected to a separate federal government program, which is the Medicaid Drug Rebate Program. Now, quick side note, in a lot of other countries, the government will do direct negotiations with pharmaceutical manufacturers, and they determine what the official price for that drug is going to be in that country. And then everyone that buys that drug in that country all pays the same price. So that's kind of the way it works in a lot of other countries. Unfortunately, we don't do that in the US. And so we have separate systems for pricing drugs in Medicaid and Medicare, and for people that get their insurance through their employer, it's all separated and everyone pays different prices. In Medicaid, the Medicaid program does have the ability to kind of negotiate discounts, or not directly negotiate, but there is a system of determining discounts or rebates from pharmaceutical manufacturers, and it comes in the form of a rebate. So for Medicaid, the list price or the regular price of the drug does not change. However, the drug manufacturer, when a prescription is paid for by Medicaid, will provide a rebate back to the state government. And so the net price, which would be the price to Medicaid after the rebate, is equal to the regular price of the medication minus how big the rebate is. Okay, so that's how drug pricing works for patients that have Medicaid. The list price remains the same. There is a secret rebate that is paid, and those rebates amounts are secret. They're only known to the drug manufacturers themselves and the people that work in Medicaid. So full disclosure, because I work in Medicaid, I do have access to this information, but unfortunately I can't share with you any of what the pricing information is because it is secret. However, I can describe general concepts. So within Medicaid, there is something known as penny pricing. Penny pricing is very interesting. That is where the rebate is actually 100%. So there is a significant amount of drugs where the cost is actually zero. So Medicaid, the rebate is 100%. Medicaid, the net cost to them is nothing to dispense certain medications. It turns out if you try to put zero into a computer system, the computer breaks. So the solution for this was to put in a price of 1 cent. So that is where the term of penny pricing comes from. So this is a well-known thing in Medicaid that there are drugs that are penny priced. And a quick reminder, I wanted to just be very clear about this. Drug manufacturers they willingly participate in Medicaid and 340B. So they are not coerced into doing this. They know exactly what they're doing. They understand all of the parameters. So I want to be very clear, because I said the examples previously about things being stolen and things being donated. That's not what's happening here. It's not stolen. It's not donated. The manufacturers, they know what they're doing and they willingly participate in this program. Okay. And so the reason why I'm talking about the Medicaid drug rebate program is that the way that 340B works is that covered entities are allowed to purchase prescription drugs at the net price from Medicaid. However, they can do that upfront. So unlike Medicaid, where Medicaid, they have to spend the full price and then they get a rebate later, 340B allows these covered entities to purchase the drugs at the net price upfront. Okay. The minimum discount that is part of the program is 23%. So just for example, if you had a drug that cost $100, the covered entity could purchase that drug for $77, and then, you know, they could choose to do what they wanted with it after that. So the minimum discount on branded drug is 23.1%. As I mentioned before, with penny pricing, many common drugs, many of which have very expensive regular prices, can be purchased for a penny, which effectively, of course, makes them free. So it's important to understand that that's how it works in Medicaid, and then that ends up affecting the purchase price under 340B. So here's this term again: stretch scarce federal resources. Covered entities can purchase those drugs at the large discounts, or as I said, in some cases, they actually acquire the drugs for free. There are no requirements for what to do with the drugs after they've been purchased. So the covered entities can do with them whatever they want. One thing they can do is they can resell the drugs to people with insurance. So people with private insurance, people that have Medicare, people that have Medicaid managed care, so the privatized version of Medicaid. Or if they wanted to, they could just resell the drugs to patients for cash and not involve insurance companies at all. So again, there's no requirements for what they can do with the drugs. They can resell them as they please. So ultimately, what ends up happening is the major fork in the road decision for every covered entity is, do we resell the drug to the patient at the same low price that we bought it for? If you were to do that, then the immediate benefit would confer to the patient, because now the patient would be paying the low price for the drug. Or do we resell the drug to the patient and their insurance company at the regular price and then keep the difference? Okay. So if you resell the drug at the full price, then that creates a spread. You keep the difference. In that case, the immediate benefit confers to the covered entity. And then in theory, they could use that money to then go and fund other stuff or unrelated services to the drug itself. So they are able to sell the drug at full price, keep the money, use it for something else. Now, if you meditate on this for a second, if the answer to this question that was being chosen by most of the covered entities was the first one, we probably wouldn't be having this meeting right now, right? Because I don't think anyone would be too bummed, or there really wouldn't be too much criticism of that program, because patients would just be buying drugs at very cheap prices. Probably not a lot of controversy there. So I think you probably can tell what option is chosen by most covered entities. So again, I want to translate 340B terminology into English, because when you try to talk to somebody who's on the inside of 340B, they often use very confusing terms to try to make you not understand what's happening. Okay, so when they say stretch scarce federal resources, what that means is they resell the drugs acquired at a discount or for free to insured patients at the full price, and then they use those profits to theoretically benefit patients by funding other stuff. Okay. 340B savings is the amount of money represented by the difference between the drug's 340B acquisition price, again, sometimes that's free, and the amount the covered entity is able to sell it to the insured patients for. So the regular amount. That's what 340B savings means, is how much they're able to make in that difference. The Health Resources and Services Administration, which most people just refer to as HRSA, is the federal government agency that's responsible for this whole program. Interestingly, there is a prime vendor that HRSA then subcontracts with, and that is a private company, which is called Apexis. And if you really get into the nuts and bolts of this stuff, Apexis is a private company that really handles most of the day-to-day details of oversight of the program. So you have a private company kind of really handling everything. And interestingly enough, Apexis is owned by Vizient, and Vizient is a group purchasing organization that is co-owned by a large number of hospitals. So the company that kind of runs this program is owned by hospitals. So that is interesting. All right, 340B inflection point. So there was a major change in 2010 around the time of when the Affordable Care Act was being passed. So the Affordable Care Act itself was enacted in March of 2010. It changed 340B in a lot of different ways, but the main way that it changed it was it kind of expanded the types of hospitals that were eligible to participate in 340B. Simultaneously, now let me back up. I want to be clear, the Affordable Care Act is legislation, right? So that went through Congress, the legislative process, all that stuff. At the same time, literally within 20 days of each other, HRSA, which is part of the executive branch, it's a government agency, executive branch, HRSA published a final rule, which is a regulation, that made a very big change in the program. So prior to 2010, covered entities, these hospitals and other various groups, were only allowed to purchase these drugs at the discounted 340B prices for pharmacies that they either owned themselves, or if they didn't have a pharmacy, they were allowed to choose one single contract pharmacy, okay? In 2010, the HRSA changes that occurred, after 2010, allowed covered entities to use an unlimited number of contract pharmacies. So any pharmacy that wanted to participate and sign up to be a contract pharmacy to support the 340B program could do so after 2010. Now, I want to be really clear about this because people get confused, and I've seen it written in many places. The Affordable Care Act itself did not make this change. It was a regulatory change by HRSA, but it happened so close to each other that a lot of times people think that this happened in the Affordable Care Act, okay? So they just happened at the same time. Now, granted, you know, the same person was president, obviously, for both of them, but yeah. So now that unlimited amounts of pharmacies are able to participate, that got people's attention. And it kind of opened up a loophole that a lot of for-profit companies that happen to own a lot of pharmacies, they saw that and they saw that as an opportunity. So here come the Fortune 20. Interestingly, you can see since 2010, there's been kind of an explosion in the number of pharmacies that participate in the 340B program. So, I mean, it's kind of just up and to the right. Interestingly, in the US, there's only about 65,000 pharmacies total. So currently, about half of all pharmacies that exist are a 340B contract pharmacy in some capacity. So remember, in order to be a contract pharmacy, you have to establish an official relationship with one of those covered entities that we talked about, and then you start dispensing medication on their behalf. So this contract pharmacy situation basically exploded. However, unfortunately, a lot of the benefit or the participation conferred to a lot of the largest organizations. So there is quite a bit of administrative overhead in participating in 340B. So if you run like a little mom and pop pharmacy, it's a lot of paperwork and just administrative headache in order to participate in 340B. So it created an advantage to large organizations that could then, you know, hire staff to just focus on all the administrative elements of 340B, whereas, you know, the mom and pop pharmacies don't really have the time to focus on that stuff. And so, as you can see, you know, disproportionately, a lot of the participation in 340B contract pharmacies, about the top 5 companies represent about 75% of all of the official 340B contract pharmacy relationships. So it's very, very top heavy. And as you can see, the total number of dollars, you know, the amount of drugs that are purchased under the 340B program has just gone way up since that kind of change in the 2010-ish area. And there's two numbers for each year here. The dark blue is the regular price of the drugs, and the light blue is the cheap price. So basically understand that the dark blue number minus the light blue number, that would be the difference. That would be the amount of money that could potentially be kept by reselling up at that higher price. So in 2021, we're looking at about $50 billion nationally. So there's a $50 billion this is why this is such a big deal. And there's a lot of people that have a lot of opinions about 340B, is that there's an opportunity for about $50 billion worth of profit.
Luke, I hope I'm not asking a question that nobody else has. Could you back up and tell us what a contract pharmacy was in 2010? And then I understand that it had a relationship with a covered entity. So
Yep.
Let's take HCMC. Was that a covered entity?
It was.
And prior to 2010, HCMC had one contract pharmacy?
So HCMC is not going to be the best example because they've always had their own pharmacies. And
Okay.
so they don't necessarily need contract pharmacies. Now, they probably do use contract pharmacies as well because they can. It expands their reach. But going back to before that regulatory change, HCMC owned several locations of their own pharmacies, and so they could have facilitated everything through that. But it would expand their scope. So HCMC, I don't know exactly which pharmacies they have relationships with, but it's like, there's no downside for them to sign up to do this. So I'm guessing that they probably have contract pharmacy relationships with Walgreens and CVS and all those 5 firms that I listed on the thing. So, definitely a change.
So prior to HRSA's final rule in 2010, each covered entity had to have a contract pharmacy because they're not in the drug business, right? And were they limited to one? That was the rule?
It was either one if they did not own their own, or they could run everything through the ones that they owned.
Okay, all right. Thank you.
No problem. Okay, so there's a lot of information on this slide, but the main important numbers here to understand is that before there was all those different types of covered entities that can participate and benefit from this program. However, it's very top heavy. So about 87% of all of the 340B purchases that exist come from hospitals. So all those other entities like FQHCs and the Ryan White programs and all that stuff, they're only 13% in aggregate. 87% comes from hospitals, and 78% comes from just one kind of hospital, which is a disproportionate share hospital. Now, my understanding is that's what HCMC would be, is a disproportionate share hospital. So just know that this program is not evenly weighted. The vast majority of the money that gets made in this program, most of it is going to this one type of hospital or disproportionate share hospitals. Okay. However, children's hospitals and the rural hospitals, they do participate as well. But if you just look at it in terms of the dollars, it's a lot of it is going to these, in the industry we call them DSH hospitals, disproportionate share. Okay, so that's where the majority of the money is going. So just a little bit more of an explainer on 340B contract pharmacies. A covered entity, which a hospital or an FQHC, they can establish an official relationship with any contract pharmacy by just registering with HRSA. For any patient that meets the definition of being a patient of the covered entity, all of the patient's prescriptions dispensed by a contract pharmacy then become eligible for 340B. The covered entity is then able to earn 340B savings, which we talked about what that is earlier, on all those prescriptions. Now, this is where we come back to the example from earlier. Everyone gets a cut, right? So the contract pharmacy will actually keep a portion of those savings. There's very little public information about the size of that portion. It could be anywhere from 10 to 30% of the total amount. Again, very, very little public information. That's really only known between the covered entities themselves and the pharmacies. However, if you look at some of the investor documents from some of the large companies like Walgreens and CVS and OptumRx, etc., the dollar amounts are so much that they are actually reporting it in their investor documents. So we're talking about hundreds of millions of dollars that those 5 big companies are making off of this program just to serve as intermediaries. So that's not they're not the covered entities. These are the intermediaries, the contract pharmacies, and they are making hundreds of millions of dollars. Now, wait, you might be asking, how do the covered entities provide the discounted drugs that they bought to the contract pharmacies? Because I mean, it just would be like a logistical problem, right? How do we actually physically move these drugs from the covered entities to the contract pharmacies? Well, they don't. So what's interesting is the ownership of the drugs is something that happens kind of like virtually, or it's like a legal artifice. The contract pharmacies don't have separate drugs, so there's not a shelf over here where there's 340B drugs and the rest of the drugs, right? They use the same ones. It's indistinguishable. The contract pharmacy staff do not know which is which. At the time, I worked for Walgreens for many years. I guarantee you I filled prescriptions that eventually ended up being considered to be 340B, but I had no awareness of whether it was or not. Retroactively, there are data analytics firms. They're called 340B third-party administrators, or TPAs is what people refer to them in the industry. They collect data from both the covered entities and the contract pharmacies to determine which prescriptions were 340B eligible and which were not. So that all gets determined retroactively or after the fact. Again, everyone gets a cut. So these TPAs also need to be paid. And this niche alone is a multi-million-dollar industry. So, okay, so let's just walk through some basic examples here, right? So let's go through the math. So step 1, contract pharmacy dispenses a prescription. The contract pharmacy receives payment at the regular price from a patient and their insurance company. So everything is just like it's any other prescription. Step 2, eventually later, the TPA determines whether there's something going on with this Buddy Robinson person. I don't know I keep getting those alerts. Sorry. Step 2 is the TPA will then determine whether the prescription is 340B eligible. Once they do determine that it's eligible, the contract pharmacy will then replenish, is the word that they use. So then that's when they go and buy replacement drugs to backfill the prescription they already filled. And they buy those drugs at the 340B price. Okay. So the savings comes from the initial payment that you received from the patient or their insurance, minus the acquisition cost at 340B that you paid to replenish or restock the drug on your shelf. Okay. The contract pharmacy then takes its predetermined cut from the contract from that savings amount. The TPA takes its cut from the savings amount, and then the TPA facilitates the transfer of the remaining monies to the covered entity. Okay. Lastly, the covered entity then uses those funds to do whatever they want. So let's go through an example. I picked out this drug because I can't tell you what the drug is, but if you're interested in health policy, I guarantee you've heard the name of this drug before. It is penny priced, so 340B entities are able to purchase it for essentially free. Okay, so the contract pharmacy dispenses the prescription. This drug, the regular price is about $7,000. Okay, so they will receive that payment from a Medicaid MCO. After the fact, the TPA determines that the prescription is 340B eligible. Then the pharmacy replenishes, so they buy that product again back at the 340B price for a cent. The savings is $7,000 minus 1 cent. Okay. The contract pharmacy takes its cut, which I just conservatively use 10%, although it could certainly be higher than that. So the pharmacy, just for filling this one prescription, is earning $700. The TPA takes its cut, which I arbitrarily chose 5%. It could be a different number, but just for this example, it's 5%. So the TPA makes $350 off of this prescription. Then you take the 7,000 minus the 700 minus the 350, and the remainder goes to the covered entity. And the covered entity gets $5,950, and then they can use that money to do whatever they want. Now, when the payer is Medicaid, which is the issue that we ran into with our legislation, there's also this concept of a medical loss ratio. So Medicaid MCOs are allowed to have a 15% margin on top of all the incurred expenses. So when these pharmacies pay the 340B covered entities, they are being charged that $7,000 that from the example previously, because that is the regular price. So that $7,000 goes into the capitation rate calculations. And so then you add on top of that 15% margin that the MCOs are allowed to get. So the way that all of this money moves from the state government to the 340B covered entities is hidden. It's baked into the capitation rates. Okay. So from the previous example, that hidden money, the state, in order for the covered entity to receive that $5,950, the state ultimately has to spend $8,050 in order for the covered entity to end up with $5,950 at the end. So from my perspective, I consider this to be inefficient, or I tend to refer to this as the leaky bucket. You know, the water is dripping out of the bucket as it moves to where it's supposed to be going. Now, this is the alternative, what we were proposing, and this is what has been done in other states. Now, under this example, the covered entity, the same thing as the covered entity pharmacy dispenses a prescription. Importantly, contract pharmacies are not allowed under Medicaid fee-for-service. So there's no Walgreens, there's no CVS or Walmart or anything like that. The covered entities have to dispense from their own pharmacies if they want to do this under Medicaid fee-for-service. Medicaid fee-for-service knows what the 340B price is for things, so it will pay that pharmacy at that price. So basically, the prescription gets filled, it gets billed to Medicaid. State Medicaid identifies the prescription as 340B. The state pays the pharmacy at the acquisition cost, which we saw from the previous example is a penny. All the 340B savings goes away. The Fortune 20 contract pharmacies and the TPAs don't get paid. And then that dollar amount doesn't get baked into the 15% medical loss ratio. So that money goes away from the MCO. Okay. So the state has now just saved a ton of money. And one of the outcomes of that, though, is that the covered entities no longer get that $5,950 from the previous example. So that's why they are particularly concerned about this. The covered entities are not getting their money. That's why they fought what we were trying to do. So, you know, to go along with this, acknowledging the fact that the covered entities will see losses of revenue in this, what I would suggest is that the state Medicaid works directly with the covered entities to come up with an alternative funding mechanism that is not tied to prescription drugs. So I just want to be clear, like when we were proposing this carve out, our goal was not to take money away from covered entities. It just happened to be an unintended consequence of that situation. This has been specifically addressed in those other states that I was talking about. So for example, New York State, when they did this conversion, they set aside $700 million a year to provide directly to the covered entities to make up for the loss of 340B revenue that the covered entities had been making from the managed care privatized version of Medicaid previously, prior to the carve out. I want to talk briefly about some peculiarities of 340B. I think these are important to call attention to. If you're interested in health policy, you probably have seen some things related to insulin over the last few years. Unfortunately, in 2017, there was a young man named Alex Smith who had difficulty affording his insulin at the regular prices. He rationed his use and ultimately he passed away. I went to a rally at the Minnesota State Capitol in his honor in 2018. I participated in that. I was trying to figure out how I could help to try to solve anything related to this insulin situation. Amy Klobuchar was there. Later, I did not know this at the time, but later, once I started working in Medicaid, I found out that several insulin products have been penny priced, that is, available for 1 cent to 340B covered entities since prior to 2017. So at the point in time when Alex Smith passed away, 340B covered entities were able to purchase insulin products for a penny, and that is still true. So if you connect the dots, it might be reasonable to ask, why have the 340B covered entities not created and promoted explicitly so that patients are aware that this exists? The promoting part of it is important. programs to resell that insulin to at-risk patients at the same cost. I mean, they're buying the insulin for a cent. So why are there not programs to turn around and just resell the drugs at cost to help patients that are having difficulty affording their insulin? That's an open question. Here's another situation. There is a drug that's kind of the main drug and has been for a long time in treating what's called PrEP, or pre-exposure prophylaxis for HIV. It's called Truvada. A couple of years ago, the Truvada patent actually expired, and so that introduced the opportunity for generic drugs to come in. And what occurred was very interesting. The generic drugs, Truvada cost somewhere between $2,000 and $3,000 per month. Very quickly, within a matter of months, there were several generic competitors that jumped in after the patent expired, and the price of Truvada fell. The generic version of Truvada fell to like less than $30 a month. So, I mean, we're talking multiple orders of magnitude. The price. The generics are very inexpensive. Fortunately, now any patients that are looking to use this medication, if they need to, they can access the generic versions of Truvada. Very inexpensive. But this is where 340B comes in. And this is from a Health Affairs article that was co-written by Tim Horn, who is one of the like preeminent health policy researchers in the HIV space. Here is the rub. The 340B program had been a big source of revenue for HIV treatment programs. And so it created a perverse incentive where the Truvada was not penny priced at this time. So I just want to make that clear. But there was a big discount on it available via 340B. So there was a big spread between the regular price and the 340B price. And what was happening is the prescriptions were getting filled, and that spread was a way for the covered entities to make money. And then they used that money to fund HIV-related programs. So when this drug lost its patent and went generic, there was actually a very strong incentive for the 340B covered entities to encourage patients to not use the generic. They needed them to stay on the brand version of the drug because that was their revenue source. So even from people within the HIV community, it was pointed out that this is creating a perverse incentive. Okay, I want to end with talking about politics. So in general, proponents of 340B believe that covered entities are better at using money to benefit patients than the alternatives. So there's kind of a degree of like righteousness to this. I kind of think about it as like Robin Hood. We steal from the rich and we give to the poor, or Batman or something like that, where they believe that they need this money to benefit the patients somehow. Okay. And they believe that they're better at using money to benefit patients than the alternative. So the alternative would mean that the patients just spend less out of pocket on their prescription drugs, right? So in that other scenario where if you acquire the drug for free and then you just turn around and sell it to the patient for next to free, the patient would benefit because they're spending less out of their pocket on the drugs, right? And this is especially important for patients that have high deductible plans. Sometimes they're referred to as being underinsured. So I don't know about you all, but I personally have a $7,000 deductible. So I'm basically on the hook for paying a lot of money at the beginning. So anything that would cause me to spend less out of pocket at the beginning would be helpful. And then the other alternative is that 340B indirectly causes private insurance companies and Medicare and Medicaid to spend more on drugs. So if we didn't use this funding mechanism for 340B, then the alternative would be that those insurers and the government programs would spend less on drugs. Proponents of 340B claim that existing programs or facilities would fold or go under if 340B ended. Now, this could be true. However, I would argue that that's not necessarily a justification for continuing the existing program as is. Perhaps we could evaluate what current programs or facilities are being funded by 340B. And if they are a good use of money, then we could provide alternative funding mechanisms to fund those things that are important. Proponents of 340B often respond to criticism of the program with deflection, right? So when you ask people kind of probing questions about 340B, there's a lot of deflections. A lot of people talk about how big pharma is bad, right? So it's okay to steal from pharmaceutical manufacturers because they're the bad guys. You know, who cares? We're stealing from the bad guys. There's also consistent messaging about how Medicaid payments are insufficient. So people that really love 340B very often talk about how Medicaid sucks. They talk about how Medicaid sucks all the time. They also claim that the program costs no taxpayer money. That is demonstrably false. Really think it's important to understand that under 340B, the covered entities get the drugs for cheap or free from the manufacturers. That makes sense. But the money that they ultimately end up keeping comes from the insurance companies. And in some cases, the insurance company is Medicaid or Medicare. So that is taxpayer money. The revenue that they are accruing, the money comes from government programs as well as private insurance companies. The cheap drugs come from pharma. So anytime you see somebody say that 340B costs no taxpayer money, that is demonstrably false. And of course, there are the intermediaries, contract pharmacies, and TPAs that benefit, in the middle. I just want to show you some quick examples of some propaganda that you see. I have consumed way too much 340B propaganda for my health, but I want to just explain this to you. So, this is a relatively benign thing. If I had to put a round ballpark number on it, currently the hospitals in the US are probably making about $30 billion a year off of 340B. So of course they are interested in keeping the program. This is an example, really representative. You could find any of these. So the threat is always, if you cut 340B, then critical access hospitals will have to cut services. So if you do anything to attack 340B, you're damaging the safety net. I got to talk about how pharma is greedy or illegal, and just pharma is bad. So we have to stand together and defend 340B. Very important. Again, there's that sense of righteousness. This one's great. So of course, 340B helps kids. You got to get that focus in there. In 2017, Medicaid underpaid 340B children's hospitals by $1.9 billion. Very common rationalization. Whenever you ask people about 340B, they always talk about how Medicaid underpays them. So we got to make this 340B money because Medicaid just sucks. And you got to protect 340B because actions that threaten 340B hurts kids, again, because Medicaid underpays. There have been lots of lawsuits. So as I mentioned, in California, they did this Medicaid carve out. The actual FQHCs in California tried to sue both the state and the federal governments to reverse the carve out. They failed, but you got to admire their gumption. In New York State, the carve out proceeded, but the whole 340B community in New York did everything they possibly could to try to make it so that it did not happen. Hochul, or however you pronounce that, that's the governor in California, or excuse me, in New York. So very interesting that in the states where the carve out was actually successful, it was led by the governors of those states, as opposed to us, where we were coming from the legislature. We were unsuccessful. Just interesting to know. With respect to partisanship and elected officials, it's really important to understand that this is not really a traditional partisan thing. So there are Democrats and Republicans that like 340B. There are Democrats and Republicans that don't like 340B. So this is not a traditional partisan thing. However, when you hear supporters of 340B from the different parties, when they talk about it, they tend to talk about different things. So Democrats that support 340B usually emphasize that pharma is bad, and that the safety net healthcare providers are very important. That's understandable. If you're interested in alternative funding mechanisms for safety net providers, that's totally cool with me. I just question whether 340B is the appropriate way to fund those things. Republicans, on the other hand, that support 340B tend to emphasize that rural hospitals have more or less based their financial solvency on 340B. We saw this in Minnesota. So the lead person that tried to kill us from the Republican side in the House, Representative Schumacher explicitly mentioned how if 340B went away, that the rural hospitals in his districts would close. So that's what Republicans tend to talk about. And some Republicans claim to like 340B because they say it's a market-based solution, which it's not, but that's what they say. Just to give you some examples, here's a Democrat defend 340B. In the same hearing, a Republican talks about rural hospitals, another rural Republican talking about rural hospitals. So this is all at the federal level. And again, this is my favorite, $0 in taxpayer money, demonstrably false. On the other hand, critics of 340B believe that the program creates many perverse incentives, unintended consequences, waste, critics of 340B believe that the program ultimately increases the regular prices of prescription drugs. So just as a thought experiment, if pharmaceutical manufacturers are forced by Medicaid and 340B to provide discounted or free drugs to some patients, I mean, these are for-profit companies, wouldn't they just turn around and raise the prices on everyone else? I mean, we have no ability to actually fully lower drug prices overall. So if you force them to give some drugs to people for cheap or free, it's just natural that they would turn around and raise prices on everyone else. In healthcare policy, this is often referred to as squeezing the balloon. And if the drug prices on everybody else are higher, or those regular prices are higher, that does indirectly increase Medicaid and Medicare spending. It's unavoidable. Critics of the 340B program believe that the program is incentivizing hospital consolidation and mergers because larger health systems generally tend to have special expertise on how to maximize 340B profit. So it does create an incentive for smaller hospitals to merge with each other so they can make more money from 340B. So my conclusions is that if we're interested in changing the 340B program itself, it has to come from the federal government. So honestly, that's probably out of scope for this group. Big thing. So let's focus on the state. In the meantime, in Minnesota, we can decide whether our Medicaid funds should be a source of 340B profit for those covered entities, contract pharmacies, TPAs, and Medicaid MCOs. So we get to decide whether or not our Medicaid dollars can be used for that. I believe 340B should not be a legitimate barrier to enacting a full Medicaid fee-for-service pharmacy carve-out. Again, the point of which is to remove waste of state Medicaid funds going to for-profit PBMs, remove perverse incentives in the pharmacy reimbursement system in privatized Medicaid, and then hopefully prevent more areas from becoming pharmacy deserts. And I believe that both the state and covered entities would be better off using alternative separate funding mechanisms not tied to prescriptions. So basically any of those services that are currently being funded by 340B and are good and legitimate services, maybe we should fund them, but just via an alternative mechanism. So I realize I ran a little long, apologies for that, but for those of you that are still here, happy to answer any questions that you might have.
Anybody have any questions? I don't know if you want to raise your hand or if you want to put stack in chat or how we want to do that. Do you want to take the slides down, Luke? And maybe it would be just easier to see everybody in case thank you.
I think everyone can unmute themselves. If not,
Yes.
I can do that for you as host. If you want to. Wow, Luke, I am just blown away. I would have to think about this for a little bit.
Dave has his hand raised. Go ahead, Dave.
Yeah, I just wonder if I missed something here. Now, why would the pharmaceutical companies, you did touch on it at the end, that they just raise prices to make up for these penny drugs. That's it? That's why they do it? Or what?
Well,
what
I mean,
go on here.
Yeah, I'm certainly not going to claim that 340B is the only reason why drug prices are too high, but I would say it's a contributing factor. I mean, there's no mechanism to negotiate overall drug prices. So it just makes sense that if we force manufacturers to give away a lot of their products for discounts or free, what's stopping them from just raising the price on everybody else? Nothing.
Right. So they aren't doing this. The government's actually saying, we want you to sell this drug to these entities for a penny.
It's not, the government doesn't say we want to. The government says, if you want to be eligible for Medicaid, you have to sell these drugs at 340B prices to covered entities. It's a quid pro quo. So if you want your drugs covered by Medicaid, and every drug manufacturer does want that to be covered by Medicaid, they have to agree to participate in 340B.
Why wouldn't they just say that's wrong because it costs us X amount to make this drug? So you're talking eminent domain here.
Oh, they certainly make that argument. They just haven't been successful yet.
Wow. for once they weren't successful at screwing people over. Amazing.
I'll just, so on that note, my politics are left of center, just in case that's not clear. But I just want to warn you, as somebody who is very much in the weeds on drug pricing, a lot of people on the left are blinded by things that happen by other entities because they're so focused on pharma. I've seen it happen over and over again that Democratic politicians can't see abuses by PBMs or hospitals or pharmacies or whatever because they're so focused on pharma. So I'll just caution you against that. Like, sure, there's plenty of blame to go around for pharma, but don't let that cause you to miss all the other stuff that's going on.
Yeah, one of the things
Okay.
that Luke was talking about with me and Representative Liebling and Senator Marty is that I think you said the article was in Dallas where there was an entity that literally opened up an insulin pharmacy. So when they get insulin for a penny, they sell it for no more than $10. And the only reason it's costing $10 is because they do have to pay the pharmacist because it has to be dispersed by a pharmacist, obviously. And they need to obviously pay the pharmacist and a little bit of overhead for the, for the pharmacy to actually exist. But if everybody could get insulin that needed it for $10 a vial, that would be huge, right? Because it is significantly more than that. So every penny they make above that penny is literally pure profit for them to use however they want. And some of them use it, as Luke said, for good things, but there's plenty of them that, it goes into their bank account as well. Did I sort of say that right, Luke?
That is accurate. And to be fair to the covered entities, I have heard of examples of them doing that. So that, so they buy the insulin for a penny and then they just turn around and sell it for a penny to the patient, right? But they don't promote it. So like, as a result, like basically no one knows about it, but I want to be fair to the covered entities. Some of them do that, but they don't really advertise.
Sure. Go ahead. I think Dawn and Paul were next, and then Mark, and you've got a good question in the chat, Mark, so hopefully you're going to ask it. So go ahead, Paul.
Look, you caught me off guard early on in your presentation. You said that the drug companies are willing to participate in 340, and I kept hearing that they hate this program.
Oh, they do.
Love to see this thing drop.
They hate it, yeah. But the status quo since basically 2010 is that if they want to be covered by Medicaid, which they all do, they have to do this. It's that simple. So they choose to do it. They weigh everything out. Now again, they might account for that, right, and then just raise their prices on everybody else. But I mean, yeah, they weigh it all out and they say, okay, we'll do it.
All right, Mark.
Yeah, Mark.
So this is probably obvious to everybody, but I just want to make sure my thinking is correct here. I'm guessing that there are no pharmaceutical companies which are only selling penny drugs into the system, that the pharmaceutical companies sell some penny drugs into the system so that they can also have some of their high margin drugs in the system, and the high margin drugs way offset the losses that they have on the penny drugs, right?
That's correct. Yep. Because the manufacturers they're either all in or they're all out. So you're exactly right. So there are some drugs that they give away for free, but then there are other drugs that they make a bunch of money on. That's right.
Yep. Go ahead.
If others of you know the answer to this question, just tell me, we'll discuss it later. But I now, at this point, after a wonderful lecture, I can't tell you why it is that HCMC would oppose either the pharmacy carve-out or our freedom to choose bill. Luke, can you give us a very short explanation on both? And let's start with the pharmacy carve-out. getting rid of the PBMs, why would HCM lose money? I don't know the answer to that.
So right now, the privatized version of Medicaid can be a payer for HCMC to earn the spread on 340B. So like say insulin, right? HCMC can buy insulin for a penny and sell it to Medicaid MCOs for full price and pocket the difference. If we went
Right.
to the fee for service model, that revenue stream goes away.
I get it. And unfortunately, it's the patient that benefits. Unfortunately, in quotes.
Well, I
'Cause
mean,
that's the other option, right? Is the patient gets.
I mean, it's Medicaid. So in all honesty, the patients probably don't really see much of a difference because copays in Medicaid are pretty minimal, right? So it doesn't really matter much whether it's MCO or fee for service because the copays to the patients are pretty minimal.
Okay, but why does the PBM have to be in the mix in order for HCMC to sell a drug at a high price to health partners?
It's a federal inconsistency. So the federal government has decided that Medicaid fee for service, the public version, cannot be a source of 340B revenue. But they've decided that Medicaid MCOs, the privatized version, can be. Now, if I were to put my tinfoil hat on, right, I think that wasn't an accident, personally. It's like I think somebody in Washington did the math and said, you know what? If we made it so that Medicaid, the privatized version of Medicaid, could provide this kind of hidden funding to the 340B covered entities, then later, when some idiot like Dr Slindee in Minnesota tries to get rid of MCOs in his state Medicaid program, all of a sudden he will earn all these 340B covered entities as enemies.
But Luke, you weren't trying to get rid of MCOs. You were trying to get rid of PBMs with the carve out.
Sorry, yeah. So in the pharmacy benefit, MCOs and PBMs they're one and the same basically. So that you got to separate out the medical benefit from the pharmacy benefit, right? So in the pharmacy benefit space, the carve out would be getting rid of both PBMs and MCOs just for prescription drugs.
And a bill narrowly tailored just to get rid of the PBMs, that wasn't something I thought that's what you were proposing.
Well, it's the same. So I mean, the MCOs are I guess involved in the prescription benefit, but they subcontract out all the actual work to PBMs. So I mean, they're intertwined. They're one and the same in the prescription benefit. Okay, so you got to separate prescription benefit from medical benefit, which pays for, hospital visits and doctor's offices and this stuff.
And so our freedom to choose bill, was it written in the original 340B legislation that HCMC can only benefit from 340B discounts if the patient is insured by an HMO? Is that what the legislation, that's what it says?
At the federal level, that decision is made at the federal level.
It says it explicitly in that act you cited at the beginning, the Public Health Act of whatever. If I look that up, I'm going to find an explicit requirement that that the patient has to be insured by an HMO.
It's not. So MCOs, just to keep it straight, Medicaid MCOs, that list that I put up earlier, right? UCare and Health Partners and Blue Plus and stuff like that. Those are eligible. Those can be a payer that HCMC can make money off of from 340B. If we take that away and the prescriptions instead get billed directly to the state fee-for-service program, that removes their ability to make the money off of it. That's why they fought us.
And so, but I think what Kip is saying is it literally written in the legislation that established the 340B program, that the way to keep that slush, as you call, the hidden subsidy, is that you have to be going through a privatized Medicaid patient versus a fee-for-service Medicaid. And so
Yeah. So to answer that question, I don't know for sure, but I'm pretty confident that it's not in the statute. It's not in the legislation. It would be in the regs that are posted by CMS and HRSA. Okay, so this is all under the HHS umbrella at the federal level, right? And famously, CMS and HRSA kind of hate each other, which is funny, just for whatever, ha ha ha, right? But this is a thing, and they don't really talk to each other. And so as a result, it creates these inconsistencies at the state level.
So Luke, your hypothesis is that if we look up the regs to implement 340B, we will see a requirement that the only covered entities that get this are going to get it through patients who are insured through HMOs.
Correct.
Okay.
MCOs,
what I find interesting is
MCOs.
that back then, very few, only a minority of states had privatized their Medicaid programs. So we had some people actually heavily promoting HMOs even before most Medicaid programs had been privatized. That's just mind-boggling, but given the groupthink that was gripping federal and state policymakers, I'm not surprised.
Yeah, and this happened. I mean, the act was passed when, Luke? I mean, the 340B Act itself, the Public Health Act, what was that, in the 80s, 70s?
Yeah. So the timing of it kind of was similar. So just the timeline, like Medicaid MCOs kind of started taking off in the mid 80s, but they really didn't like actually gain a lot of traction until the early 90s. So it was kind of that, Bill Clinton neoliberalism era kind of thing is when privatized Medicaid took off. The Medicaid drug rebate program went into effect in 1990. And then 340B was started in 1992. So all this stuff and the intersections of all of it goes back like 30-ish years.
It
was a move. So the original version, like the LBJ version of Medicaid, is what we still have is fee for service, right? And that's what I'm an advocate for. Is just the old school, fee for service Medicaid. None of this private company stuff. But in the 90s, unfortunately, and you see it in Medicare as well, with Medicare Advantage. Now we have these privatized versions of government programs.
But just one last comment. So it may be that we don't have to get an act of Congress. What we may need is to get some bureaucrat in CMS to get off his duff and rewrite the regs.
At the federal level, sure, but we can fix this at the state level without even involving the feds if you want.
I understand that. Yeah. Okay. Thank you.
Go ahead, Ann.
Well, my original question was going to be to ask Luke to review how this harms independent pharmacies. So I got two questions, I guess. How do we stop this program from harming independent pharmacies? And secondly, apparently, if we ran into this barrier with the Freedom to Choose bill, if we try to fully deprivatize or go to fee for service for all public programs, we're going to run into the same obstacles, only on steroids, right?
Yep.
Because of all the money they're used to getting.
Yep.
These hospitals are accustomed to getting.
So with respect to independent pharmacies, it's the PBMs that are the killer, right? So that was I'm going to be honest with you. A year ago, I didn't know anything about 340B at all. Never thought about it. Never cared. Didn't need to. They came after me, right? My issue was the PBMs. So I went after the PBMs and I thought we were going to win. And then they came in from the side and kind of sidestepped us, right? So so the hospitals is sidestepped us on the thing. So which was interesting because politically, like, nobody cares about the PBMs. Like, they were not going to be a problem for us politically. It was the Democrats folded because the hospitals leaned on them. That's what happened. Yeah, and so with respect to independent pharmacies, the state under Medicaid, the states hand over the money to these PBMs, and then the PBMs kill the pharmacies.
Mhm.
So they're actually doing it with state money in a lot of cases. And then the other thing about 340B is that it creates a competitive disadvantage, because remember that example where I said the pharmacy fills one prescription and makes $700, right? So if you're a pharmacy that has access to that, and you're versus a pharmacy that can't earn $700 on one prescription, it creates a competitive disadvantage for independent pharmacies versus the bigger organizations that have that tailwind. So it's kind of a 340B is kind of a double whammy in trying to kill small pharmacies.
Yeah. Sharon, unmute if you would, and unmute Sharon, please. Sharon? Sharon, can you unmute? Sharon, we can't hear you.
Bottom left, Sharon, bottom left, maybe by the mute. Stop video. Well, then we can't hear you then, Sharon.
I can't seem to unmute her. Can you put your question in the chat? Why doesn't, even as host, this is the commands are not working.
You can send me the question in an email. That's fine. Yeah, just email me. Are there other questions?
Luke, I have a question about, in the course of working with the legislature, what reaction did you get from Republicans representing rural parts of Minnesota? Or did you have the opportunity to have that conversation?
I mean, we had a ton of rural Republicans that were ready to support our carve-out bill because of the list that I showed you. I mean, they know that a lot of these small towns, their pharmacies are closing and not coming back, right? So, you know, it comes down to they were supportive of us until they got leaned on by the rural hospitals that make money off of the 340B thing. So it's the same thing. It's, you know, the hospitals have this kind of weird subsidy that they make for the 340B. So, I mean, if you're a rural legislator, I guess you know, you're having the small pharmacies telling you, hey, we're closing and there's no pharmacy in your town. But then you have the rural hospitals saying, hey, the thing you're trying to do to fix that is going to kill the rural hospital. So, I mean, I guess I have some sympathy for them, but like, that's why to me, the solution of this is to find other funding mechanisms for the rural hospitals so that they get money that's not tied to 340B.
Exactly.
I got my mouse to work,
Sharon,
by the way.
on. Thanks.
I think. Can you hear me?
Yes.
Yeah.
Okay, I'm sorry, my mouse just is not working. And now, now I've got something else that came up. I don't know, my computer is going crazy. So I'm wondering why the MCOs do not complain about having to pay the safe $700 for a drug. Is it because they could go back to the state and tell them we need more money for Medicaid, so they don't really care?
Yeah. So remember the medical loss ratio part of it. 15% of a bigger number is more than 15% of a smaller number. So they don't really have an incentive to actually lower costs.
That's what I thought.
Luke, have you written this down?
I mean, I'm working on something. I actually think this should be a book, but I want to find somebody who's actually a writer, so I can convey all this stuff to them. But I've started writing in the Minnesota Reformer. I had a piece on consolidation in CVS. If you just Google Minnesota Reformer and my name, you'll find it. I want to focus my efforts on legislator education right now, because in all honesty, like the general public is never going to care about this. It's too it's too behind the scenes. It has to be a health policy legislator thing. So I'm kind of focusing all my 340B efforts on, number one, picking fights with people within the pharmacy community, because a lot of pharmacists love this because they make a ton of money off of it. So they're just like, oh, we love 340B, So like when I go to, you'll notice this carve out thing, and I could not get the Minnesota Pharmacists Association to support what we were doing, because there's too many pharmacists that work for hospitals that make all this money off of 340B.
Wow.
So it's a civil war even within the pharmacy profession. So, I mean, I'm focusing on legislator education right now, but I could definitely get around to writing about it eventually.
And are you at risk of losing whatever it means to be a contractor for Medicaid?
So what's kind of beautiful about this is that I'm not the only person on this warpath. So in general, anybody that works in or is an advocate for Medicaid fee-for-service, which I am, hates 340B nationally. Like are you familiar with, I'm not going to say his name, but we have a Medicaid director here, the person who's responsible for Medicaid pharmacy in Minnesota. Because of my job, I know that person in 25 states. Okay. So they, without exception, everybody that works in Medicaid fee-for-service despises 340B, because it's this toss-up of, if you believe in Medicaid fee-for-service, you believe in a public version of healthcare programs, and 340B is like maximally privatized. So in my job, I'm only saying the things that everybody that I work with also believes. So I'm not at any risk of being fired or anything like that, if that's what you're asking. I'm protected.
Good.
It sounds like Representative Liebling is very receptive to this information. Is she, and Rose is on here, and able to kind of convene a critical mass of legislators to listen to this information, or at least the Health and Human Services Finance Committee? And how about the Senate side?
Well, I know Dr. Slindee is certainly working directly with Representative Liebling, and she did talk a little bit, didn't she, Luke, the last time we met, about the potential of doing some kind of whether it's a hearing sort of format or something like that, to really get this education out to legislators. And I, earlier when Dr. Slindee first joined us, I told him that since I'm meeting with Senator McEwen and Marty on Thursday afternoon, that I would pitch this as a really good training for the Minnesota Health Plan Caucus members, assuming that's still a thing and it's up and running. And if not there, if there's any way that we can pressure the DFL caucus to just get educated about this, so that, these legislators know what's going on when they're confronted with the bills that we're trying to get passed, I think that would be really helpful. But Dr. Slindee's willing to do this anywhere.
Yeah,
and he's willing to do it with legislators. Just
to be clear, this is, you guys are the guinea pigs. Like, this is the trial run, and we're going to be doing the same presentation with as many legislators as possible. And coming out of the last meeting that Rose and I had, I believe the plan is for Representative Liebling and Senator Marty to get us an audience with all of the DFL.
Great.
But just to be clear, I will tell this to anyone. Republicans, anybody, like, this is not a partisan issue. This is a money issue, it's not just a Democrat thing.
And, we do. Oh, sorry. Go ahead, Sharon.
Why are you leaving the Republicans out?
I'm not.
He's
not. It's just that what happened is, because we were meeting with two Democratic legislators at the time, they just said that the power they have to call together would be their own caucus, and that would be DFL. That's not to say that there won't be outreach to the Republicans. It was just one sector that they knew that, or they felt they could get in a room to hear this first, for starters. No, we definitely, it's not like Luke said, it's not a partisan issue. Nobody's is leaving them out. It was just, is it a good place to start by, yes, he's been working directly with legislators that happen to be DFL. Could they at least get a training with the DFL legislators, because they are in the majority right now, but that we want to train everybody, all legislators on it.
Okay, I understand that. You know, our group is nonpartisan and we have, I'm with Health Policy Advocates and we have Republicans, Green Party and so on, but we do have Republicans that support our bills. So I just.
We did too.
wanna let you know.
We did
You
too.
did too.
Yeah.
Yeah, we had Republican co-sponsors in both the House and the Senate.
Okay, all right.
It's the omnibus thing is the problem.
Right.
Yeah, I know, and education.
Yeah, educating people so they understand this a little bit better. Yeah,
Yeah.
very true. Go ahead, Ann, and then we should wrap up in about
Yeah.
5. I know I have another board meeting tonight at 6:30 and dinner just arrived, so I might have to jump off and run it, leave it to you, Ann. But if I do, Dr. Slindee, thank you so much for doing this.
Wow.
I think it was wonderful. I don't have any feedback right now for change, although I know there are a number of people that sort of focus on doing trainings and education who are on this tonight, and they might have some feedback. So I'll make sure that we get your email address out to folks in case they want to throw any thoughts at you. But I thought it was eye-opening, and the more I get into it, the more, angry I get about it, but it's stuff we have to know. So thank you for that. Go ahead, Ann.
Oh, this was absolutely enlightening. Thank you so much. I just have a title for your talk. It's called 340B, Pigs at the Trough.
Yeah, pretty much.
That'll get people to sign up for you.
Yes.
You're
How
not
many
wrong.
pigs fit at that trough?
Yeah.
Yeah,
Go ahead, Kip.
I second the motion. This was
Excellent.
extremely useful.
Oh my God.
We need to be able to make the case against the use of 340B as an excuse to prevent the pharmacy carve out and the
Yeah.
freedom to choose bill. I don't feel prepared yet to do that. This was extremely helpful. And the reason I asked you, have you written something, even just for legislators, in 3
Well,
pages or 4
yeah.
pages?
Well,
We need to be able to figure out how to make the case ourselves, and I'm looking forward to working with you on how to do that.
So we're going to distribute the slides, and also I believe that this recording is going to be available as well. So if you want to go back and rewatch it or look at the slides, you could do that. If the questions come up, my email is in the slides. Just ask me.
Thank you very much.
I think Judy said we can post on I guess YouTube has a private channel that we can use in
It
case
does.
we don't want it out in
Yep.
the public yet.
Yeah, and I think we don't. We want to use the private
So
version
we'll
for now.
keep
But yeah,
that kind of proprietary at this
Yep.
time.
Yep.
And really, really, really appreciate this information.
Yeah, and I mean, and it might be something for the education committee
Uh-huh.
to consider, like for whether it's a quarterly meeting, whether it's an education night, when we get back in the swing of those after we get done with the state fair and everything, and if we're going to
Yeah.
go back to doing, monthly education sessions, I think people would be find this really fascinating information to have, and Dr. Slindee's willing to do that for us. So I think we really need to wrap up though, everybody, because we are right on the edge. Again, thank you so much, Dr. Slindee, for doing this. Thanks everyone for coming. Great information. And I hope to see you soon, Luke, in Tina's office again, so we can keep brainstorming.
Yep. All right. Thank you.
All right. Sounds good, everyone. Thanks.
Bye.
Bye-bye.